Okay, Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, colleagues everywhere. This is again back to Zoom, and we have a great speakers and a great topic to discuss. So, you hear about HIF, MERF, HERF, PEF. This is not another cardiology or heart failure meeting. It's about to know where that the cardiology heart problems not happen in isolation, happens with other problems. And that's, I think, the significance of tonight's meeting. Two experts, one is cardiologist, one is nephrologist, endocrinologist, whatever you want to say yourself, ourselves. Nowadays, we become, I don't say I'm cardiologist, I could be CKM, I think. So that's the whole idea. Professor Hussein Hishmet, he's a cardiologist, interventional cardiologist, but tonight, as I said, he's like a CKM, and myself and Dr. Agarwal tonight. So we go through the HIF, MERF, HIF, PIF, challenges management. Then we talk about, certain therapy in this field. So Prof. Hussein Hishmet, enlighten us, please.
Thank you, Dr. Abdullah, for the kind introduction, and I'm glad that we're starting together again. Thanks for the host for bringing us together for speaking about this topic, which is HEF, MREF, HEF, PEF. And I hope that by the end of my talk, we reach an agreement about the name HEF, MREF, HEF, PEF. So let's talk about heart failure first. Heart failure is a widely prevalent condition. More than 60 million individuals worldwide have heart failure, and it seems to be increasing because as we are doing a greater job in the management of myocardial infarction and hypertension, people will survive, and heart failure becomes the final pathway of all cardiovascular conditions. And heart failure is not just as malignant as cancer, because 50% of the patients will die within 5 years. It's also depleting the healthcare resources in terms of healthcare expenditure, the years lost, and also the number of hospitalization. Heart failure is the prime cause of hospitalization in individuals above the age of 65. And so what's heart failure? Heart failure is a clinical syndrome where the heart is unable to function or function properly to supply blood to the needing tissues, or it can do that only at an elevated pressure. And so the heart has two functions, a systolic function and a diastolic function. And our easy tool to assess systolic functions is ejection fraction. To assess diastolic functions, we have multiple parameters, and we don't have clear numbers like we have in the ejection fraction. That's why we used to characterize heart failure by the ejection fraction. So less than 40 is reduced ejection fraction. From 41 to 49, that's mildly reduced, a middle term. More than 50% or more is heart failure with preserved ejection fraction. And that was part of the universal definition of heart failure. So they added heart failure with improved HEF, IMPEF, if the patient had a baseline less than 40 and then he recovered for some reason. So we had at least four classifications of heart failure based on the ejection fraction. And to make it even a little bit more complicated, women tend to have a higher ejection fraction, higher normal ejection fraction. So the normal ejection fraction in a man would be 55, whereas in a lady it would be 60. And we had different terms, not just HEFREF, HEFMREF, we had HEFNEF, heart failure with normal ejection fraction, which is more than 55 in men and more than 60 in women. So I get the feeling that there is confusion about the terminology. Forget about the fact that ejection fraction has a wide variability in measurements. I can measure it now and get, let's say, a number of 40. Another technician or a physician can read the ejection fraction as 44. To the patient doesn't mean much, but it would move the patient from one category to the other. And these patients, especially with heart failure with ejection fraction more than 40, are increasing in prevalence. I don't know why. Maybe because we're recognizing them more. In the old days, we used to say that these symptoms are coming from COPD or from just frailty or aging or anemia or chronic kidney disease. But now across the board in different registries, Heart failure with mildly reduced and with preserved ejection fraction is roughly seen in almost 1/2 of the patients with heart failure. And it's not the same. Heart failure with reduced ejection fraction has striking differences from that with preserved ejection fraction. So these are the two extremes. And in the middle, there's the mildly reduced ejection fraction that shares features from both. For heart failure with preserved ejection fraction, the dominant features are female gender, atrial fibrillation, chronic kidney disease, much more common than in HFrEF, non-cardiovascular risk factors. Mind you that the most common cause of mortality in patients with HFpEF is non-cardiac. It's due to cancer and infections. Whereas heart failure with mildly reduced ejection fraction is a mix, has features of both reduced and preserved ejection fraction. And despite this increasing prevalence, the prognosis remains poor. And the prognosis remains more or less the same with reduced, mildly reduced, and preserved ejection fraction. The need for hospitalization and the poor prognosis applies roughly the same for all the three subcategories. And it's easier to understand that if we compare the bar chart in purple, which is the normal survival in the US, versus the three lines, green and blue and black. You see, there is almost no difference in the survival between reduced, mildly reduced, and preserved ejection fraction. So they have the same poor prognosis. But for some reason, and because we discovered it earlier, heart failure with reduced ejection fraction, the therapy has evolved dramatically. Now we have 4 foundations of therapy that, if added together, they are able to improve the outcome by more than 64%. So we cut 2/3 of mortalities just with the foundational therapy. And we have also clear indications and contraindications for almost every aspect of therapy. Those with a wide QRS complex, those with refractory heart failure, those with persistently low ejection fraction despite medical therapy. And we have first-line agents and we have second-line agents. Vericiguat, I hope it comes back one day. Digoxin, it's starting a comeback. Potassium binders when indicated. Edge-to-edge mitral repair and surgical revascularization whenever it's indicated. So it seems that we have gone a long way when it comes to heart failure with reduced ejection fraction. But when we look at heart failure with mildly reduced or preserved, it's entirely different. Many therapies have failed. Beta blockers, ACE inhibitors, most of the ARBs. Diuretics offer no mortality advantage. They just help to relieve symptoms. And so what remains in our hands, based on, let's say, the latest American guidelines, is just SGLT2 inhibitors, perhaps ARNI, perhaps MRA, perhaps ARB, and that's only candesartan. But you see, the only agent that has even a class 2, not even class 1, are SGLT2 inhibitors in patients with ejection fraction more than 50. So I compiled the guidelines, the ACC Expert Consensus Pathway on HFpEF, the 2022 guidelines on heart failure in general, and more importantly, and actually this deserves a little bit of attention, the Canadian Cardiovascular Society guidelines on heart failure that were published late in last year. And I like this term, and I wish that we all adopt this simple term rather than the term preserved and mildly reduced. This term is non-reduced ejection fraction, HFnREF. They compile preserved ejection fraction, mildly reduced ejection fraction under one umbrella, which is an ejection fraction more than 40. They call it HFnREF. So we have HFrEF and HFnREF. And I think this will help us clear a lot of the confusion that results from variations in the ejection fraction measurement, the different cutoffs of a normal ejection fraction in men and in women. So this is the term that I would recommend and I would start to adopt. HFrEF and HFnREF. And it's a simple number. 40 or less is reduced, more than 40 is non-reduced ejection fraction. So this is the term that I would like you to remember from this talk. And whether it's HFpEF or HFnREF, it has a mix of pathophysiological contributions. Hypertension, obesity is a strong component, diabetes, chronic kidney disease, obstructive sleep apnea as part of the obesity and the metabolic syndrome, atrial fibrillation, even to the extent that there are some theories or understandings that heart failure with non-reduced ejection fraction is not a cardiac condition. It's a cardiac affection secondary to some systemic disease, could be in the kidney, could be obesity, could be diabetes, or sleep apnea, etc. So that's one aspect of the complexity of HFpEF. The comorbidities are multiple and conflicting. The other issue is the diagnosis. Because these patients come with multiple comorbidities or polymorbidities, and the classic symptom is dyspnea, but there are other symptoms like fatigue or weakness or syncope, many chest pain, many symptoms. But let's focus on dyspnea. Dyspnea on its own can have cardiac, pulmonary, and other causes of dyspnea. That's why these patients are frequently missed in the diagnosis, because we lived for decades on the notion that heart failure means a reduced ejection fraction. So to help us, we need to understand the basic concept. To help us in the diagnosis, we need to understand the basic concept. We need to have some symptoms and signs caused by heart failure and some structural functional abnormalities and elevation of the pro-BNP. And looking here at the thresholds for pro-BNP in HFpEF or HFnrEF, they are much lower than in those patients with heart failure and reduced ejection fraction, because a big proportion of these patients are elderly, and because diastolic dysfunction on its own does not elevate the pro-BNP as systolic function does. So a simple clinical calculator that can help us suspect HFnrEF is the H2FPEF clinical score. And it's very easy. If you just sum a body mass index more than 30 and atrial fibrillation, that's 3 points in an elderly patient above the age of 60 or hypertensive, then you get 6 points. Then 6 points or more is highly diagnostic of heart failure with non-reduced ejection fraction, even without measuring the pro-BNP because of some of the fallacies in heart failure with non-reduced ejection fraction. One of the criteria that I love to look at are the annular velocities. If you find the medial annular velocity less than 7 or less, the lateral annular velocity less than 10 or 9, then you score big points towards the diagnosis of heart failure with preserved ejection fraction. But we need to understand that, again, it's a heterogeneous condition with multiple mimics. It's not just chronic kidney disease, atrial fibrillation, elderly, and obesity. Could be cardiac amyloidosis, and we are not doing the best job when it comes to diagnosing cardiac amyloid. We need to refer more patients based on the clinical suspicion to technecium pyrophosphate scan. And now that genetic testing is becoming available and it's offered by one of the companies, it's going to help in the familial forms of cardiac amyloid. Hypertrophic cardiomyopathy is rather easily diagnosed because it affects a younger age, and there's a peculiar picture on echocardiography or cardiac MRI. But there will be other situations that mimic HFpEF, like nephrotic syndrome, volume overload, among other conditions like hemochromatosis, Fabry disease, myocarditis, and pericardial diseases. So let's take two hypothetical situations where both have an elevated H2FpEF score. On the left side, a 68-year-old lady with severe chronic kidney disease, atrial fibrillation, obese, hypertension, so she gets the full mark when it comes to the score, a score of 9. But let's look at the other patient, score 6, 68-year-old man, also chronic kidney disease, atrial fibrillation, but he has some of the red flags of cardiac amyloid. So although he scores high in HFpEF, the workup of this patient needs to include technetium pyrophosphate scan or genetic testing. So heart failure with preserved ejection fraction or non-reduced ejection fraction, symptoms, structural abnormalities, elevated pro-BNP, we need to be vigilant of the mimics and the non-cardiac causes, chronic kidney disease, liver disease, pulmonary disease, etc. So we've talked about the pathophysiology and the diagnostic caveat. Now, what do we have? The pillars for guideline-directed medical therapy. And now the therapy of HFnREF is evolving. If you look at the previous slides, there was only one drug that was class 1, whereas SGLT2 inhibitors were class 2, but these were the old guidelines. And looking again at the Canadian guidelines, now we're starting to have a clear roadmap to managing these patients. We have on the left foundational therapies, and we have phenotype-driven add-ons. So the foundational treatments are SGLT2 inhibitors and MRAs, whereas the add-ons are for some specific phenotypes, not for everyone. So an obese patient with a body mass index more than or equal 30, ejection fraction more than 45, then GLP-1, semaglutide, tirzepatide, they do a great job. Whereas a patient with systolic blood pressure more than 100, ejection fraction in the early 50s, then we use ARNI. But these are just add-on treatments, not for everyone. Let's go back to the foundational therapy. Again, these are the Canadian guidelines. We have MRA and SGLT2 inhibitors, and we'll try to get a hint which one is more effective when it comes to reducing hospitalizations. Add-on therapy for morbidly obese, GLP-1, for hypertensive patients, ARNI or candesartan. We need to give some remembrance to candesartan because it's mentioned in the guidelines. Of course, loop diuretics for symptom relief, treatment of comorbidities, and some non-pharmacological approaches because many of these patients are frail, elderly with multiple comorbidities, so their prognosis can be guarded. So let's look at SGLT2 inhibitors, and they made a huge difference. I remember that the launch of empagliflozin with the Emperor Preserved, followed by the dapagliflozin with the Deliver, was a breakthrough because we didn't have any medications that improved hospitalizations convincingly other than SGLT2 inhibitors. But if we look at the residual risk, which is the risk of having an event even after taking empagliflozin or dapagliflozin, the risk is close to 20% in both conditions. So the residual risk is huge. The absolute risk that we got with empagliflozin or dapagliflozin is 1.8. And I need you to remember this number. The absolute risk reduction with SGLT2 inhibitors is 1.8. So let's look at the other neurohormonal pathway, which is the renin-angiotensin-aldosterone system. We've seen the Paragon with ARNI and the Charm with candesartan and the TopCat with MRA, and they give us a hint that RAS activation plays a role in the pathophysiology of HFnREF by glomerular injury and cardiac fibrosis. And now we have at least 3 MRAs. We have the non-steroidal MRAs and the steroidal MRAs. The classic steroidal MRAs are spironolactone and eplerenone, and the non-steroidal MRA is finerenone. So how do they differ? Finerenone and spironolactone have the same potency, stronger than eplerenone. Remember that 25 milligrams of spironolactone is equivalent to 50 milligrams of eplerenone. The selectivity, finerenone is the most selective, comes next eplerenone, and comes last spironolactone. So spironolactone is the least selective. The side effects, erectile dysfunction, gynecomastia, no signal in finerenone, whereas in spironolactone, it's one of the main causes of discomfort for patients. Finerenone doesn't have active metabolites, same applies to eplerenone, whereas spironolactone has a long-acting effect, which gives it an advantage in one situation, which is resistant hypertension. But looking at finerenone, it has the same or even more potent than spironolactone and eplerenone. It helps to block the mineralocorticoid receptor, and so inducing renal protection and cardiac protection effects. It has a short half-life, it is highly selective, no effect on androgen and progesterone, so it doesn't give the gynecomastia or the sexual side effects. So how does finerenone compare to eplerenone when it comes to the heart? Tested in experimental animals, finerenone, when given at equivalent doses, had a much stronger effect on inhibiting cardiac fibrosis and cardiac inflammation in experimental animals. When we look at finerenone versus spironolactone on the kidneys, then again, the effect of finerenone on reducing fibrosis, urinary albumin excretion is much better than spironolactone. So forget about experimental animals now. Going into the clinical studies, what did the steroidals MRA give us in heart failure with mildly reduced or preserved, the NREF, or with chronic kidney disease? We can keep the talk about the heart failure outcomes to the discussion, but I remind you that the TOPCAT study was given FDA approval based on a subgroup analysis. If you look at the total population that included Russia and Georgia, there was no benefit from spironolactone. But looking at the US population, there was only the benefit. But let's forget the heart now. How about the kidneys? We know that eplerenone and spironolactone were associated with impairment of chronic kidney disease. They didn't slow down the progression of chronic kidney disease. Actually, the curve of placebo was better than the curve of eplerenone and was better than the curve of spironolactone. So these agents may be good, or they are good in heart failure with reduced ejection fraction, spironolactone in resistant hypertension, but not in chronic kidney disease, and probably not in heart failure with non-reduced ejection fraction. And of course, the notorious hyperkalemia, 20% increase in the absolute risk of hyperkalemia. Also, the efficacy of steroidal MRAs, especially spironolactone, tends to decline as the eGFR declines, and of course, the risk of hyperkalemia tends to rise sharply. So we're always crippled by spironolactone-induced hyperkalemia and renal side effects. So let's again to the randomized controlled trials. We've seen how mediocre were spironolactone and eplerenone and how miserable they were in chronic kidney disease. But how did finerenone perform in heart failure with non-reduced ejection fraction? And here comes the FINE-HEARTS heart failure trial. This included more than 6,000 patients, and they included 3 doses of finerenone based on the eGFR, 10, 20, and 40. And they included patients with an ejection fraction more than 40. So this is HFnREF. And they were on diuretics. They had elevated proBNP, but they excluded patients with an eGFR less than 25. So this is the exclusion criterion. And patients with resistant hypertension, patients with coronary disease. And they followed the patients for close to slightly less than 3 years. And they looked into heart failure mortality and heart failure hospitalizations. And they looked also into some secondary endpoints. How did the patients look like? 20% of the patients had acute heart failure in the previous 3 months. Actually, 20% had decompensated acute heart failure within the previous 7 days. So it's not a study on acute heart failure, but after recovering from acute heart failure within less than a week, patients were given finerenone. And elderly patients, as most of our patients with HFnREF, female gender in almost 50% of the patients. The mean ejection fraction was 52. Majority of patients function class 2 and 3. And looking at the eGFR, again, elderly patients with HFnREF, a big proportion have chronic kidney disease. So almost half of the patients had an eGFR that is less than 60. The background therapy, everyone would ask, where is SGLT2 inhibitor? At the time the study was designed, we didn't have the data of the benefit of SGLT2 inhibitors in heart failure with preserved or mildly reduced ejection fraction. So their use at that time reflected their use in diabetes and heart failure with mildly reduced ejection fraction. So what did the study find? Finerenone resulted in a 16% relative reduction in the combined endpoint of death and hospitalizations for heart failure. 16% may not seem very impressive, but look at the absolute risk reduction. It's 3.3%. Remember the absolute risk reduction that we got with SGLT2 inhibitors? It was 1.8. Here we're even getting double the benefit that we saw with SGLT2 inhibitors, even although a proportion of patients were on a background of SGLT2 inhibitors. And this shows you the beneficial and the benefits and the glory of this finerenone in patients who have almost no decent options. The endpoint was mostly driven by reduction in heart failure hospitalizations. Cardiovascular death was numerically low with finerenone, but it was not statistically significant. And we can discuss in the discussion afterwards why that finding. But if you want to think which one to start first, then think of which one is going to give you a bigger benefit. Finerenone will result in 29 fewer heart failure hospitalizations for every 1,000 patients, whereas SGLT2 inhibitors would give 11 fewer hospitalizations. I believe that we need to combine both, but in that hypothetical question where you're left only with one agent to give, then it's probably going to be finerenone. Looking at other beneficial effects, the chronic kidney disease effects, significant reduction in new onset microalbuminuria, significant reduction in new onset macroalbuminuria, 38% and 24%, irrespective of the baseline eGFR. So it doesn't only prevent cardiac events, it prevents deterioration of eGFR. Another bonus effect is the prevention of diabetes. And this is very important in the cardiovascular conundrum because statins increase the chances of developing diabetes. Some beta blockers also increase the chances of developing diabetes. So if you add finerenone, then it's probably going to buffer this diabetogenic effect that we see with other cardiovascular medications. So reduction of heart failure events, microalbuminuria, and prevention of diabetes. Also, we get an improvement in the Kansas Cardiovascular Questionnaire, which was significant. All-cause death, it's very difficult to achieve in heart failure with non-reduced ejection fraction. A big proportion of mortalities are non-cardiac. So it's unlikely that any cardiovascular effect has a beneficial effect on all-cause mortality. So does the baseline use of SGLT2 inhibitor buffer the effect or dilute the effect? Actually, no. Patients who are on an SGLT2 inhibitor get a 17% relative risk reduction. On no SGLT2 inhibitor, they get 15% relative risk reduction. So there's no p-value for interaction. Up till an ejection fraction of 60, the benefit is there and statistically significant. But if we cross the point of 60, then we don't have any drug or probably intervention up till now that can improve the mortality if the ejection fraction is more than 60, and that's a point that we can discuss. Now, it's an MRA, so people would be concerned about the side effects, the hyperkalemia. So the side effects were similar between finerenone and placebo. A rather relatively high rate of frequent events, side effects. But again, these are patients with multiple comorbidities, pulmonary, renal, infections, so they are more likely to discontinue the treatment. Now the question of hyperkalemia, because we were all bitten by hyperkalemia when we used spironolactone. So how does it change with finerenone? Hyperkalemia, total events of hyperkalemia, which is more than 5 or 5.5, was less than 10%. Leading to hospitalization is 0.5%, fatal hyperkalemia, none. And this should be taken in context that the dose went up to 40 and almost half of the patients had a form of chronic kidney disease. So hyperkalemia leading to hospitalization in less than 1% of patients is a breakthrough. So there's no question now, if you have a patient with HFnREF, should you give him a steroidal MRA or a non-steroidal MRA? Because for the steroidal MRA, the benefit in HFpEF is not clear. They have some antiproteinuric effect, but their effect on declining eGFR slope is not there. Whereas finerenone, proven by the fine arts and proven by other studies on chronic kidney disease, is the clear winner whenever it's heart failure with non-reduced ejection fraction. So the only MRA that was shown to demonstrate significant benefit in patients with heart failure and an ejection fraction more than 40 is finerenone. Reduction in combined cardiovascular death and heart failure events, consistent across ejection fractions, baseline use of SGLT2 inhibitors with a very tolerable side effect profile. But finerenone is not the end of the story. We need to consider the comorbidities. Anticoagulation for atrial fibrillation, other agents for chronic kidney disease, control of type 2 diabetes, management of coronary artery disease. And again, these patients are really complex to treat because of the comorbidities and the advanced age. So they need a team to optimize their guideline-directed medical therapy, the 4 foundations that we have, working hand in hand with the pharmacist and with the rest of the medical team. So I need you to go out with the new term, heart failure with non-reduced ejection fraction. Remember, we have 2 foundational therapies, SGLT2 inhibitors and finerenone. Finerenone probably gives double the benefit of SGLT2 inhibitors when it comes to heart failure hospitalizations. Remember, ARNI when there's hypertension, and GLP-1s when there is obesity and an ejection fraction more than 45. Thank you so much.
Great. Thank you very much for that overview of HFmERF or HFnERF, whatever. Every day we get different definition. Doesn't matter. So for people, you made the two of them, NERF.
Yes.
NERF
REF and REF.
REF. خلاص الله يعين. طيب. Today, as I said, we are in the field of bringing everything together. CKM, and with Dr. Agrawal is a cardiologist from Cleveland, but endocrinologist, nephrologist, and cardiologist. So Dr. Agrawal, take us use of finerenone in CKM. This is a new terminology where the cardiologist with the nephrologist, with the endocrinologist, with metabolic, but we want to see if the point of view of cardiologists of using finerenone in CKM. Dr. Agrawal, please go ahead.
Thank you so much, and thank you so much for Bayer to organize this event, and Dr. Hashmat for setting the stage with different phenotypes of heart failure dependent on the ejection fraction. I think as we were discussing in the final slides of heart failure with preserved ejection fraction or mildly reduced ejection fraction, the comorbidity burden, other than the cardiovascular comorbidity burden, is very high. And that's where the whole concept of cardio-kidney metabolic syndrome comes through. So for example, you have, this was coined almost 3 years now by American Heart Association in their scientific statement paper, where they were looking at different types of phenotypes. For example, you have a patient which is stage 0, has no risk factors, is healthy, and then eventually over time can belong to different stages. Honestly, looking at this, this cartoon or flow chart, most of our patients will go randomly between some stages and eventually land in stage 4, presenting as clinical presentations. But for stage 1, they have described the concept of excess dysfunctional adipose tissue, where overweight, obesity, abdominal obesity, and impaired glucose tolerance phenotypes will be included. Stage 2 is more metabolic risk factors. Now the patients are progressing. They're developing disease of hypertension, hypertriglyceridemia, metabolic syndrome overall, type 2 diabetes, and also moderate to high risk CKD. And as you can list here and focus that these are non-metabolic etiologies of CKD, which we are focusing on, and non-metabolic etiologies of hypertension that we would be focusing on. Moving forward, then you have your subclinical cardiovascular disease and the CKM syndrome, where the patient underlying in their body has subclinical atherosclerotic cardiovascular disease or subclinical heart failure, and they belong to stage 3. I think at this time point, the field is not that advanced to kind of decipher and discover these subclinical atherosclerotic cardiovascular disease. That's why we are calling them subclinical. Honestly, most of the times when patients are presenting this spectrum of this worsening of this underlying cardiovascular disease has already started. So we, as the field moves from the imaging and the biomarker tools, this stage 3 will kind of become close to like stage 3.8 or 3.9, very close to stage 4. And then we have finally our clinical cardiovascular disease in the CKM syndrome, where we are seeing patients with coronary heart disease, heart failure, atrial fibrillation, stroke, and peripheral arterial disease. As cardiologists, most of the time, we are focusing on patients on stage 4. But the way the field is moving, we have to focus more and more on the cardiovascular risk factors to avoid this progression of CKM syndrome. Also, they have included the risk equivalence of subclinical cardiovascular disease in CKM stage 3, where they have included very high risk CKD populations such as stage 4 and stage 5 CKD, or by the KDIGO heat map, which we will touch upon in the upcoming slides. And then you have your different risk predictor tools. You can use your pooled cohort equation, or with the CKM paper, they came up with the PREVENT calculator. There is the SCORE calculator that the European societies are most focused on. Dr. Hashmat was talking about the HFpEF score in those two case scenarios where you're trying to predict the probability of patient having a clinical HFpEF without even doing an invasive assessment of their hemodynamics or the filling pressures. That's where the tool and the power of these risk prediction tools comes through. So albuminuria honestly can often be detected before eGFR decline, and it predicts the increase in the cardiovascular risk. But the whole problem is most of us are not focusing on albuminuria. Most of us are not focusing on ordering or assessing the urine albumin creatinine ratio. Overall, this has been known for the last 30, 40 years that it leads to more cardiovascular risk, but we never had the tools to address this albuminuria. So here on your x-axis, you have your albuminuria, and then on the y-axis, you have your urine albumin creatinine ratio range, which is being denoted by the same color of purple. On your secondary y-axis, you have your eGFR, and you can see in this particular diabetic population, time since the type 2 diabetes, you're looking at these blue lines, which is basically their eGFR, and then this purple line, which is their urine albumin creatinine ratio. As the time from the diagnosis of type 2 diabetes increases, the level of the urine albumin creatinine ratio starts to increase, and you would see a very steep decline in their eGFR as their urine albumin creatinine ratio picks up. Honestly, the urine albumin creatinine ratio starts deteriorating and starts becoming abnormal prior to the decline in the eGFR. Hence, it precedes and speaks for the deterioration at the kidney nephron level from different stresses. They can be cardiovascular risk or the non-cardiovascular risk. And eventually, you will see that as the urine albumin creatinine ratio really picks up, and as the eGFR really crosses that cutoff of 60 eGFR, the decline in the renal function is very steep, and the decline in the increase in the urine albumin creatinine ratio is also very steep. Just speaking that albuminuria is often detected or can be detected before the eGFR decline, and it speaks for the increase in the cardiovascular risk. Different guidelines have hence included both eGFR and urine albumin creatinine ratio testing at least annually in all the patients with type 2 diabetes. And if you look at different guidelines, such as the American Diabetes Association, KDIGO guidelines focusing more on from the kidney societies, or the ACE from the endocrinology societies, both of them have emphasized, all of them have emphasized that do not look at just eGFR as a measure of kidney function. You have to look at urine albumin creatinine ratio because it's measuring the kidney damage, and the other one is measuring the kidney function. So honestly, it's a very strong biomarker that we have that precedes and speaks for the deterioration in the kidney function. And if identified and recognized in time and reverted, the eGFR progression can be very different, as we will also talk from the landmark clinical trials. So at least annually, we have to do this. All the guidelines are recommended both eGFR and urine albumin creatinine ratio to properly identify a stage and monitor CKD patients and type 2 diabetes, as eGFR alone may miss the earlier stages of CKD. eGFR is just kidney function. Urine albumin creatinine ratio is speaking for the kidney damage. And it supports routine eGFR and albuminuria screening to assess early cardiovascular risk. It has been very well known for the last 30 to 40 years that both eGFR and albuminuria speak for the cardiovascular risk profile of these patients. It's just that more recently, we have put them together in this CKM theme, looking and calculating using the PREVENT calculator, specifically looking at the risk of heart failure and the risk of ASCVD or the overall mortality. And why does it matter? because kidney and cardiovascular system, they talk a lot, and it's the most beautiful integrated system inside the human physiology. The mineralocorticoid receptors are overactivated, are present in both kidneys and cardiovascular, causing the damage through inflammation and fibrosis. So on your left, you have your kidney and the heart disease, the MR pathway, it becomes overactivated. That can be due to different insults and different mechanisms. What happens next is the increase in the reactive oxygen species, more gene expression of different enzymes such as NADPH oxidase, which are pro-inflammatory, leading to more cytokine release and are pro-fibrotic in the nature. And hence it causes inflammation and fibrosis at the kidney level, causing the kidney damage, glomerular damage, proteinuria, tubular injury, reduced renal blood flow, kidney injury, starting a cascade of events, which is a vicious cycle to break. Also, it's causing vascular damage. It's causing vascular remodeling, endothelial dysfunction, increased vascular stiffness, and then eventually leading to heart damage, where you have myocardial hypertrophy, ventricular remodeling, fibrosis, reduced coronary blood flow, ischemia, infarction, and myocardial injury. And hence, all of this can be teed up and can be pinpointed back to the MR pathway over activation. How have this basic science data or the theoretical data translated in terms of clinical trials from agents such as finerenone, which are very highly selective non-steroidal MRA, as we were talking about in the previous presentation, with a very high selectivity and potency for the binding. And these MRA receptors are distributed both in the heart and the kidneys. And the problem that we had from previous MRAs, which were steroidal MRAs, was very diffuse distribution or non-selectivity for action on these different receptors. But finerenone particularly has a very high concentration and accumulation pharmacokinetically, both at the heart and the kidney level, and more in the heart if we go into the pharmacodynamics and the pharmacokinetic data with a short half-life of 2 to 4 hours. So we have had landmark diabetic kidney trials where the overall outcomes, if you see, cardiovascular disease is the #1 cause of death in CKD population, in diabetic population. So Fidelio DKD and Figaro DKD assess the pre-specified kidney outcomes in patients across the spectrum of CKD severity. So for example, Fidelio DKD was much more advanced population, more higher stages of CKD. Figaro was more like intermediate, as you can see here. And when you combine both, you have the Fidelity pooled analysis, which kind of showed that when you have A2 or A3 profile of albuminuria, this agent came out as a big winner. And the start of the glomerular function started from as early as stage G2. That's what these different slides are showing up. If people are not aware of this colored chart, which has green, yellow, and red colors in it, this is the KDIGO heat map. On the y-axis, you have your albuminuria categories, where you're measuring the level of albuminuria, A1, A2, and A3. Normal to mildly increased, that is less than 30, 30 to 300, and then more than 300. And then on your y-axis, you have your traditional measure of EGFR categories, where you have G1 to G5, G5 being worse, less than 15 EGFR, and G1 having normal glomerular filtration rate of more than 90. If you just focus on G1 on the first line, and if you're just focusing on G1 with the EGFR measurement, you will miss out on proportion of patients who belong to A2 and A3, just assuming that they have normal glomerular function, because you are not focusing on albuminuria, which is the urine albumin creatinine ratio that this KDIGO heat map and different studies over past several years have described as a cardiovascular risk factor. So what did the Fidelity pooled analysis showed? It was basically combining the landmark results of Fidelio DKD and Figaro DKD trials, which was including population from CKD stage 1 to 4, having both severities of profile. So for example, in the first trial, we saw the composite cardiovascular endpoint. There was a 14% relative risk reduction with the number needed to treat 46, with a robust hazard ratio of 0.86 and a p-value of 0.0018. The hospitalization risk for heart failure, even in these diabetic kidney disease clinical trials, there was a 22% relative risk reduction for the hospitalization for heart failure, having the hazard ratio of 0.78. If we go to the kidney endpoints, we saw 23% relative risk reduction with the number needed to treat of 59, and the hazard ratio of course, 0.77 with a very robust p-value. And this composite kidney endpoint included time to kidney failure, sustained more than 57% eGFR decline, or kidney-related death. And if you look at patients who actually progressed, who were progressing to dialysis in this pooled cohort analysis, you saw 20% relative risk reduction for the patients to have dialysis when you were combining both of these. And there was a median robust follow-up of 3 years. More than 13,000 patients were included, 70% male, mean age of 65 years, and hemoglobin A1C of average of 7.7. Prior heart failure hospitalization, 7.7% population. And 99.8% of these patients were on some kind of a RAS pathway inhibitor, such as ACE inhibitors or ARBs, and 72% were on background therapies of statins. So these patients kind of describe the real world population on background RAS pathway inhibitors and statin therapy, diabetic kidney population, with landmark results as shown in this pooled cohort analysis of Fidelity from Fidelio DKD and Figaro DKD trials. Also, finerenone reduced the urine albumin creatinine ratio by 32% between the baseline and at month 4 versus placebo. So this improvement in urine albumin creatinine ratio, you saw very early. Within, basically, when we are seeing patients, we give them usually 3 to 4 month follow-up during for such sick population. So by the time this patient is coming for your next clinic visit and you're repeating the urine albumin creatinine ratio, you will already start seeing a reduction in the urine albumin creatinine ratio as denoted or as supported with this trial. A lower mean urine albumin creatinine ratio with finerenone versus placebo was maintained throughout the study. So once it declined, it stayed like that throughout the study. So as you can see, the blue line is describing the geometric mean urine albumin creatinine ratio and the changes. And you see right there at this 4-month mark, you're seeing around 36% reduction in the urine albumin creatinine ratio, which increases to even more than 40% over time period. Finerenone, as we were talking about previously, increased hyperkalemia, but the clinical impact was minimal. For me, hyperkalemia needs to be described as clinically significant hyperkalemia and then the rest. The clinically significant hyperkalemia, which is causing hospitalizations or ER visits or the discontinuation of the therapy, those are the endpoints and the numbers we should be focusing on. The investigator-reported hyperkalemia adverse events, if you look at the finerenone, which is denoted here in blue, is around any kind of hyperkalemia was 14%, while in placebo also it was 7%. But if you see the hyperkalemia leading to permanent discontinuation, this 14% number went to 1.7%. And then hyperkalemia leading to death is 0. So adverse events with clinical consequences, if we focus on adverse events with clinical consequences, the hyperkalemia leading to permanent discontinuation significantly is around 1.7%. The maximum difference in mean serum potassium levels between the finerenone and placebo was 0.19 millimoles at 4 months. So you might say, yes, these patients are having hyperkalemia, but if you compare it to placebo, the maximum difference in the mean serum between the finerenone and placebo was 0.19 millimoles per liter. And these patients, the hyperkalemia risk factors, not surprisingly, are those who already have higher baseline potassium, have lower eGFR, higher urine albumin creatinine ratio, and also was found to have higher beta blocker use in this population. But with a robust potassium management strategy guided by regular potassium monitoring, there were no hyperkalemia-related deaths in around more than 13,000 patients over the median follow-up of 3 years, which is very impressive. How has all of this data, different guidelines have incorporated, leading to the key updates for the treatment of patients with CKD and type 2 diabetes and the role of finerenone in treatment paradigm. If you look at different guidelines for the management of CKD and type 2 diabetes, you can look up the ADA KDIGO consensus. They are talking about, again, a similar approach, which is the 4-pillar approach. If you're looking at the ESC, European Society of Hypertension, KDIGO guidelines. They're talking about RAS pathway inhibitors in the background. They're straight away talking about non-steroidal MRA. They're not talking about steroidal MRA. They're just mentioning non-steroidal MRA, finerenone by the name, which is the only clinically approved, randomized clinical trial studied molecule that we have in this day and age. Then they are talking about SGLT2 inhibitors. And now more recently with the FLOW trial, we have started talking about GLP-1 receptor agonists also. And hence this pillar approach is aligned with multifactorial holistic approaches for the treatment of CKD type 2 diabetes as recommended by both AD and KDIGO. And we keep on emphasizing the major cause of death in CKD and type 2 diabetes patients is cardiovascular disease. And the improvement that we saw in the outcomes of these patients, other than the slower progression of their CKD, was majority of it was driven by cardiovascular events. There has been key updates in the 2023 ESC guidelines on the management of patients with CKD and type 2 diabetes. So for example, if you have a patient with whose initial presentation of cardiovascular disease or type 2 diabetes, you have to check, does this cardiovascular disease patient has type 2 diabetes, or the other way around, has this type 2 diabetes patient has cardiovascular disease or CKD. And if it is confirmed, at the bottom, you're looking at the treatment of GLP-1 receptor agonists, SGLT2 inhibitors, and particularly finerenone as class 1 recommendation for this patient population. So for the treatment of patients with type 2 diabetes and CKD, of course, you need a statin-based regimen to reduce their cardiovascular risk. Most of these patients will be or should be on the ACE inhibitors or ARBs to reduce their kidney failure risk. And to reduce their overall cardiovascular and kidney failure risk, you have to focus on blood pressure control, finerenone, non-steroidal MRAs, and the SGLT2 inhibitor, which has been described. The focus update of 2021 ESC guidelines for the management of heart failure is also straight away reflecting that for the prevention, and we are talking about prevention till date, it has been very tough to find therapies for the prevention of heart failure in this very high-risk population of CKD and type 2 diabetes. But it has been mentioned and recommended. Finerenone in patients with CKD type 2 diabetes recommended class 1 recommendation to reduce the risk of heart failure hospitalizations. Going back to the FINE Heart study, it was an integrated pooled analysis of finerenone across 3 phase 3 clinical trials of heart failure and CKD and type 2 diabetes. These patient population of HEF, mid-range ejection fraction, preserved ejection fraction over time, anything above more than 40%, different clinical trials. If you look the percentage of patients who have different types of CKM conditions, as denoted in these lines, majority of them have more than 2 or more CKM conditions. Hence, the prevalence of non-cardiovascular and cardiovascular risk factors, the metabolic risk factors in this patient population is very high, which speaks for the interplay between the cardiovascular disease, kidney disease, metabolic risk factors, and this CKM syndrome. This FINE Heart was an integrated pooled analysis of finerenone in more than around 19,000 patients across 3 phase 3 trials of heart failure and CKD. Now we are talking about combining Fidelio DKD, Figaro DKD, and more recently the FINE Heart's heart failure trial, which had around 6,000 patients. It included both patient population which had with or without type 2 diabetes and had ejection fraction more than 40%. And of course, in the DKD, Fidelio, and the Figaro, you have patients which have the other way around, the CKD type 2 diabetes with or without the presence of heart failure population. The design and methodology of these phase 3 clinical trials included right here. They all are phase 3 randomized clinical trials. The cardiovascular composite endpoint was cardiovascular death and total heart failure events, which has also been studied as a secondary endpoint in the Fidelity study, which was a composite of Fidelio and Figaro, having here the cardiovascular composite endpoint. Figaro had a primary endpoint of cardiovascular composite endpoint, and the secondary endpoint was kidney composite. If you look at the FINE Heart study and their overall combining all 3 clinical trials in one, you have to understand that the definition of endpoints for cardiovascular disease differed slightly between the trials. And this key thing in the differentiation of a definition for different endpoints kind of covers a huge spectrum of endpoints that we commonly come across in our clinical practice. So for example, in Fidelity, we had deaths of undetermined cause, were considered cardiovascular. The fine arts, we had deaths of undetermined cause were not considered cardiovascular. So we are kind of comparing and including both profiles of cardiovascular death, determined or with undetermined cause, when we are looking at these analysis. This pre-specified sensitive analysis in fine arts considered all undetermined deaths as cardiovascular deaths. 90% of the patients enrolled in fine art had overlapping CKM conditions. As you can see here, again, one CKM condition, two CKM condition, majority had more than two, more than 75% of the patients, and three CKM conditions in around 12% of the patients. The baseline characteristic enrolled were actually representative of patients that we regularly see on a daily, day-to-day basis. How many heart failure with preserved ejection fraction patients do we see who have no other problem? At least they have two or three CKM problems that we have talked about. The characteristics of the fine art population were largely consistent across all the treatment groups. If you look at the average eGFR and urine albumin creatinine ratio, it was consistent between both arms. Background medication was consistent between both the treatment arms. And what finerenone led to was associated with the significant reduction in cardiovascular death when including undetermined death, which was a pre-specified sensitivity analysis. The primary endpoint, the primary analysis of cardiovascular death. And if you look at the cardiovascular death of undetermined death, again, you are seeing the hazard ratio of 0.88 in the pre-specified analysis with the p-value of 0.025, leading to 22% relative risk reduction. So using the primary cardiovascular outcome definition derived from fine arts, finerenone was associated with a non-significant reduction in the risk of cardiovascular death as shown here. And using the cardiovascular outcome definition, the Fidelity trials, the risk of cardiovascular death when included was significant as reflected right here. The effects on the primary endpoint of cardiovascular death were broadly consistent regardless of baseline use of medication. Sometimes we are questioning, oh, patient is on this background therapy, should we add another or not? Honestly, we have to think in terms of pathways and not in terms of number of medications. The more the pathways you can block, the more the residual risk that you can reduce. So for example, GLP is a different pathway, SGLT2 is a different pathway, and this MRA is a completely different pathway. And hence, when you block on top of these pathways, you are leading to the reduction in the residual risk for these patient population. Finerenone demonstrated significant benefits in pre-specified cardiovascular and kidney endpoints versus placebo. As you can see again here, for the kidney composite endpoint, heart failure hospitalization, cardiovascular death or heart failure hospitalization, new onset atrial fibrillation, major cardiovascular events and death, all-cause mortality, death, and all-cause death or all-cause hospitalizations, all of them were highly significant as demonstrated here. The incidence of new onset atrial fibrillation was significantly lower in patients treated with finerenone versus placebo by 17% in heart failure population. Atrial fibrillation is a very common problem, which many of us believe is due to the fibrosis of the tissue. And hence, when you see an agent reducing the incidence of new onset atrial fibrillation, it speaks for the pathophysiology changing anti-fibrotic effects of the molecule per se. So new onset atrial fibrillation, there was a 17% relative risk reduction with a hazard ratio of 0.83 over a median follow-up of 3 years, as you can see here with the finerenone. The beneficial effect of finerenone on new onset atrial fibrillation was generally consistent across all the subgroups. If you look at these different spline curves, it reduced the risk of cardiovascular death and total heart failure events, regardless of their baseline NT-proBNP level. HFpEF population will trick you because their NT-proBNP level will only be marginally elevated or a lot of times normal, because it just speaks for the underlying pathology that these patients can carry. But the clinical benefit was seen regardless of the baseline NT-proBNP level, speaking again the pathophysiology, anti-fibrotic, leading to the myocardial changes, vascular changes, kidney changes, and at the level of cardiovascular level, which are translating into the hard clinical endpoints as denoted in these studies. It was associated with early and substantial reduction in NT-proBNP versus placebo when it was elevated, as you can see here, placebo being denoted in this orange line and finerenone being denoted here in the green line. As you can see in these dot plots, there was a 12% placebo-corrected treatment effect as soon as 3-month follow-up, which persisted at 12-month follow-up of placebo-corrected effect. So FINE-HEART confirmed the beneficial effect of finerenone across a range of cardio-kidney outcomes, including all-cause death in a broad range of CKM population. The effects were consistent regardless of baseline medication use and level of underlying CKM comorbidities or the number of CKM comorbidities. It demonstrated benefits in other pre-specified outcomes, including the kidney disease, all-cause death, and heart failure hospitalization. It was very well tolerated with a well-characterized, modestly higher risk of hyperkalemia. And in this day and age of potassium binders, I don't see even that number of high potassium can be treated with overall lower incidence of serious adverse events and no excess risk of acute kidney injury. Finally, we have the FINOVATE program we will be talking about in the final slides. It's investigating the efficacy and safety of finerenone in patients across the spectrum of kidney disease and heart failure. So FINOVATE, it stands for finerenone non-steroidal MRA for improved kidney and cardiovascular outcomes. It has basically two arms, Thunderbolt or the Moonraker, as you can think of. Thunderbolt basically encompasses the clinical trials in patients with CKD and beyond, which is Fidelity, FIN-CKD, non-diabetic CKD, Fiona, FINE-1, Confidence, which the results are out, FIN-CKD, the results are out, Fidelity, the results are out, REFINE-DR, very promising results are being shown. CKD type 1 diabetes results should be coming out at the end of this year, very promising results. And the Moonraker trial program aims to address the key evidence and implementation gaps for finerenone, and it will generate data in more than 15,000 patients with heart failure across different clinical settings. Again, FINE-HEART's redefine heart failure, confirmation heart failure, and finality heart failure. If you look at the different population, you will see a consistent theme of more than 40% on the top two studies, but the confirmation heart failure is independent of LV ejection fraction, and finality heart failure, you are talking about HFrEF who are intolerant of non-eligible steroidal MRA. So now we are taking and studying the population with HFrEF also in this Moonraker program. Thank you so much for your attention, and I would be happy to take any questions. Thank you.
Much. Thank you, Doctor. Excellent. Now, I think time for questions and comments. I just, before I start, since Hussein Hashmat, you started with this. Are you with us, Hussein?
Yes, I'm here.
All right. Just because, I had lots of questions here from the audience. I put things together. You talked about an area which is, again, debating, it's evolving every time. And then Dr. Agarwal, as a cardiologist, talked about area which is, again, new to us. I mean, let's be honest. If this buyer did not come with this medication, we're not talking about this CKM. But I can see that HIF, PIF, HFrEF, or whatever you want to call it today, it's in the stage, when the damage already happened. So if we forget about, ejection fraction, if we talk about CKM from beginning and focus on that from beginning, we're able to, detect that early. Every patient CKM at the stage 1, stage 2, then stage 3 maybe subclinical. We'd have prevented all this problem. What's your thought, both of you?
I'll give you my input first. Chronic kidney disease is just part of the gear box that fuels the development of heart failure with non-reduced ejection fraction. It's a major contributor, but it's not alone. Aging on its own results in fibrous tissue replacement of the heart and induces HFnREF, just mere age relation. Chronic obstructive sleep apnea is a major driver, and other conditions as well. So I wish that we are able to prevent heart failure with non-reduced ejection fraction. Maybe if we control blood pressure more and control chronic kidney disease at an early phase, then maybe we might prevent the development of HFnREF, but that still needs to be proven. We don't have a plethora of literature that tells us that if you do this intervention, then you will prevent HFnREF particularly. We have data on prevention of heart failure when we control blood pressure or treat coronary disease or diabetes, but not specifically for HFnREF.
Dr. Agarwal, what I'm trying to say here is we, as a cardiologist, always act at the end. When we have events like symptoms, signs, that's where we intervene. That's what I'm trying to say here. CKM, it's a start early. When there's hypertension, obesity, micro dysfunction, all this happen at the beginning, which is, not seen. These are, most of cardiologists in the past were not involved, involved by primary physicians, by diabetologists, again, things not done properly. Now we have therapies which is evidence-based, has got outcome, but its benefit will not come at the end when we have events. It's even better we start early. I know we need data, but what you've done as a cardiology in this field, because I think when cardiologist comes on, things move. This happens in every field. In diabetes, with GLT-2. Happens with aspirin, with hematologist, we took over. Same with the lipids. When the cardiologist comes in, takes. But what should we do in terms of CKM to have a better management because we still have, doctor, lots of residual not targeted yet in HFpEF. Still people die. 50% you say mortality. Must be something we need to do more work before we reach that stage. So your input and what we do as a CKM. We know we have a therapy now, but we do more work.
Absolutely. I think we have always been a reactive field. Like when we see something, then we were reacting. Now the field of prevention cardiology, if you go 5 or 10 years, it just meant treating the lipids or starting someone on aspirin, which also is now kind of controversial. But with these advent of therapies, which are acting at the tissue level and also changing the cardiovascular events in a very high risk cardiovascular population, it just changes the whole field. Now you're looking at the patient, not at their heart, but you're looking everything surrounding the heart also. How can you protect the heart? If you can reduce the risk of CKD, if you can reduce the residual risk of their urine albumin creatinine ratio, if you can keep that patient out of the hospital for any reasons, if you can cause weight loss, reduce the insulin resistance, improve their blood pressure, I think it's a plethoric drug. And honestly, finerenone, because of its such a high selectivity for the MRA receptor across the heart and the kidney for the first time in this patient profile, I think is a game changer for those reasons.
Excellent. Look, let's go to the questions we have from the audience here. Many of them, okay, some of them your answer, but let's start with a nice question which I've seen at the beginning. It talks about where is it going again? First question. Okay, this one is, what about normal culture HFrEF and HFNERF? It talks about, what do you think of that, Dr. Hussein Hashmet? Is this
What's the question?
normal circulatory HFrEF, HFNERF? Is that circulation, is it normal in these patients with HFNERF, HFMERF? What about that? Asking that question, which is, I think is,
question. He means
I know it's a bit difficult. Do you see it? The first one, AH. Or we can move to the second one if that's what I thought is a bit, interesting because
yes, Dr. Abdul Hamid, I think he's asking about the nomenclature of HFrEF and HFNREF.
Yes.
Actually, I like it. It's not mine. I didn't invent it. It came from the Canadian Cardiovascular Society, a very respectful society. We still grade the angina by the Canadian Cardiovascular Classification. So we should respect their classifications. And they decided to go out of this hassle of MREF, mildly reduced and preserved and normal. They divided into two. Just a sharp line, ejection fraction 40. Whatever below 40 is reduced. Whatever is above 40 is non-reduced. It's a clear dichotomous 0-1 black and white classification. That's why I like it. And they combine together all the therapies for the HFNREF into 4 types or 2 types, 2 foundational SGLT2 inhibitors and MRAs, and 2 add-ons, which are the ARNI if the patient has a decent blood pressure, or GLP-1 if the patient is obese. And as interventional cardiologists, we are simple people. We like the percent stenosis, we like the ejection fraction 40, and we like simple thinking. That's why I like this classification.
So do you think, doctor, regarding the reason we are missing HIF, because one of the problem I have normally, I say to the doctors, we have 2 days or 3 days on heart failure, and everyone talks about HIF-PIF, but then I ask them a question, simple question, how do you diagnose it? They give you a lousy answer, symptoms, signs, and echo and all that. But the question is, if you do that at rest, maybe you get one answer. If you do it at the stress, you get different answer. Maybe that kind of questions. Do we need to a dynamic physiology and to know the phenotype of the patient? Do we need to stress the patient on the echo to know the answer? I mean, I don't know. What do you think?
It's
To know
not
that,
a
because
for the
impaired
diagnosis.
relaxation, impaired the stiffness, macro
It's not.
dysfunction, you will not know it at rest. You maybe need to hemodynamically stress them.
The idea is intuitive, but it's hard to apply for every patient.
Yeah.
Because how will we stress the diastolic function?
Yeah.
We know that, for instance, dobutamine induces some myocardial stress, but I'm not sure what would be the effect on diastology. So I'm not sure of the answer. But anyhow, we have criteria. We have the scoring system. And as I mentioned, I like to look into the annular velocities. If the annular velocities are reduced and everything else is normal, then I keep heart failure with non-reduced ejection fraction high in my differential diagnosis just by simple annular velocities. And they are available on all machines. Global longitudinal strain is not available on all the machines. But any hospital that has an echo now and they have tissue Doppler, you can easily get the medial annular velocity, the S wave less than 7, the lateral annular velocity, the S wave less than 10 or 9. Then there is something going on bad in the myocardium. The ejection fraction is normal, so it's non-reduced, but the annular velocities are reduced, so there's something abnormal. Going for stress is definitely something nice, but practically it would make things harder to achieve in reality.
So, Dr. Agarwal, with the
Yes.
finerenone, one of the concern people have is hyperkalemia. Do you think, one of the question here from Dr. is anonymous, hyperkalemia is so common, shall we use the, potassium sparing or something, to treat the potassium therapy with the medication? What's your answer?
So, first of all, that we need to understand is that the hyperkalemia that led to death was 0 in the studies, and also the second thing that led to the discontinuation of therapy was around 1.5%. Okay, so yes, the overall hyperkalemia, if you compare to someone who is not on finerenone, will be higher. That's the first thing, and the second thing, because if we have a balanced approach towards the risk and the efficacy ratio. For example, efficacy of finerenone versus the risk efficacy ratio is pointing towards the efficacy of the agent. So I would do everything I can to keep the patient on finerenone and change things surroundingly, where the potassium binders, the role of potassium binders, and the dietary modification becomes a key. Also, the data shows that when these agents are used in background therapies or combination therapy with SGLT2 inhibitors, the risk of hyperkalemia actually attenuates even more. So the studies are coming up when you're doing the combination approach, even this concern is much lower. And plus, we have great therapies for potassium binders. So I would do everything to keep the patient and continue the patient on finerenone, because the efficacious effect is so high to just discontinue because of that hyperkalemia concern. Also, I want to add something on the discussion we were just having regarding the challenging them for the stress test for the diastolic dysfunction. I think what you touched on upon a great thing. A lot of patients come to us and they say, I'm symptomatic when I walk, when I do something. They are okay at rest. So now I'm using resting studies, resting echo, resting biomarkers to say, oh, you are okay. But they are clearly telling you in the clinic, when I walk or when I do something, when I run, when I climb stairs, that's when I feel. At rest, I'm not feeling something, right? So that's where I think the most recent American Society of Echocardiography guidelines just released 6 months ago. They have the whole algorithm where they're saying if this patient has this, which is completely normal, still the clinical suspicion is high, as you were portraying, challenge them with exercise and look at their echo parameters. Yes, it's going to be cumbersome, but it's very reasonable to give that patient an answer. You know what? At rest, you don't have symptoms, but I'm going to do something at exercise because you are symptomatic when you are doing something. So it kind of answers both. So that's my approach towards using the diastolic stress testing. And some of the labs in the world are also doing invasive stress tests where they're putting a Swan Ganz and then exercising the patient, which is a very different thing. But at least with the treadmill, doing an echo and saying, how are you feeling? And then measuring the parameters at that time point can help us answer that.
Okay, so we have now the question is about some of the therapies which we all familiar with, like RASI and ARNI and beta blocker, aldactone, spironolactone. These medications we are familiar with, been with us for a long time. Their role in HFpEF, HFmERV, which mentioned today by Dr. Hussein Hishmet. And I also would like you to also comment, Dr. Agarwal, since this is part of CKM, patient with hypertension, with a bit of diabetes, proteinuria. I know the RASI and ARNI got some role. So both of you in that direction. Start with
So, yeah,
questions are from the audience, by the way. I'm trying to collect them together.
Yeah, I saw the questions about beta blockers in HFpEF, and the studies that we have showed no benefit. So you might give them for the control of rapid atrial fibrillation. That's probably the only indication I can think of. And even in that situation, we don't have an evidence of improved hard endpoints. ACE inhibitors also, perindopril at least, didn't show any benefit. For ARBs, the only tool, irbesartan failed, but candesartan in the CHARM preserved showed a reduction in hospitalizations. So it gets class 2B in the guidelines. And the data for valsartan comes mainly from the ARNI, from the Paragon, where it has been demonstrated in subclasses, subgroups of females with an ejection fraction, I think less than 58, that ARNI are beneficial. For spironolactone, we have the data from the TopCat, and it was a big mess and buzz because if you look at the totality of the data, spironolactone didn't improve the outcomes. But it seems that the results were contaminated by the results from some countries where there was non-adherence to spironolactone. So the trial in total was, I think, to me, like a mess. So these are the data that we have for spironolactone, ACE inhibitors, ARBs, and beta blockers in HFnREF.
So, Dr. Hussein Hishmet, let me just put it in this way, okay? I don't know if this patient got HFpEF or HFmERV, okay? Patients got diabetes, hypertension, and I'm treating this patient. Patient got, of course, got shortness of breath there, a bit of edema there, but I'm treating patient for hypertension, diabetes. The role of the RASI, ARNI, beta blocker here, and ischemic heart disease.
Okay, that's a different story because most of what we're talking
what I wanted
now,
you to bring all this forward, because I think this is where because I don't think we can see HFpEF in pure. It's very difficult to find. I don't know. I've never seen HFpEF purely, very rarely, but must be some other comorbidity with it. Either patient female, ischemic heart disease, it must be something else with it. I don't know. Have you seen a HFpEF alone without any of these comorbidities? Very difficult.
yes, we see it in elderly ladies. Those elderly ladies, we see them actually because of other comorbidities, and they just come out of discovery accidentally. They have a dilated atrium, a normal ejection fraction, reduced annular velocities, and elevated proBNP, and the symptoms are vague, but we see them in the community. Back to the question about stage B heart failure. This is where the therapies come in to prevent the development of symptomatic heart failure. So the ACC-AHA staging of heart failure. A is everyone who's at risk. Any hypertensive is stage A, any diabetic is stage A. Then stage B, where there's been some injury or structural change, but it's short of causing symptoms. For instance, someone with a myocardial infarction and an ejection fraction of 45, but he's asymptomatic, that's stage B. or someone who's hypertensive and has left ventricular hypertrophy, or someone with chronic kidney disease who has left ventricular hypertrophy. Stage B, what actually works in stage B heart failure are ACE inhibitors. Probably this is the best that we have, and also with some evidence for ARBs and beta blockers. ARNI doesn't have an evidence to support in stage B, because stage B are practically asymptomatic. They have zero symptoms. They are functional class 1. And the majority of these patients are not represent. The studies that we have do not include a lot of asymptomatic NIHA class 1, because it's hard to demonstrate a benefit in these patients. So in those patients, before they are symptomatic at all, before they develop clinical heart failure, the evidence that we have is for RAS inhibitors and beta blockers.
And then the role of the SGLT2 finerenone together in these patients.
SGLT2 inhibitors would be useful for chronic kidney disease. It will slow down the progression of chronic kidney disease. The same applies for finerenone. And doing that, they will prevent heart failure hospitalizations. But honestly,
when they have HFpEF, to start
I'm
them
not
together,
sure
or
if
which I mean,
maybe Dr. Agrawal would comment more on that if we look at the Fidelio and the Figaro. They prevented hospitalizations. Where they HFrEF hospitalizations or HFnREF hospitalizations, I don't know.
Okay.
So,
Right. Dr. Agarwal, we have a cheaper, like MRA, spironolactone, and some of selective patients benefited from this in the studies. Why should we go with finerenone?
no, I think that's the cost issue definitely will be something that the level of efficacy that we are achieving can that actually justify the cost. So, for example, spironolactone, right? Like people can buy out of pocket. It's that cheap. It has been along for that long. But honestly, is that actually helping the patient? That's my counter argument. So, for example, we have had this therapy for the last 25 years. How many trials and controversial results, and still daily on a daily basis we are seeing. So if a patient asks me, you know what, I have can I do this instead of that? My answer might be, it also very patient dependent. It is very patient dependent on the patient profile. But eventually I'm thinking, should I give them something that maybe will not act, but it's cheaper? So, but might give them all the side effects, which will lead to stopping other agents that they might be on. So, for example, ACE, ARB, or hospitalizations for different reasons, kidney function issues, hypotension. So, if I'm using an agent, I better have a very good reason rather than just the cost. Now, the second thing is, because of the very high selectivity on the MRA and the distribution of this molecule, the antifibrotic effects at the vascular level, endothelial level, and the cellular level, decrease in the atrial fibrillation, heart failure hospitalizations, diabetic CKD population, or ejection fraction more than 40% population till date. It's very impressive and kind of creates a very strong argument of using it upfront without not waiting for anything or just thinking about the cost. So definitely it is something, but if there is benefit, the cost can be justified, because what is the cost of heart failure hospitalization, HFpEF, when this patient actually shows up in the hospital, right? So that is something that we have to think about. Something that you were talking about, I think the one of the question is effects of MRA on mortality and 6-minute walk test in heart failure patients. I think Dr. Heshmet was also describing these patients, asymptomatic patients, right? If the patient is completely asymptomatic, to avoid and see the improvement in their 6-minute walk distance. What is the data? I think we have had data with eplerenone. There was a study, like a very small cohort study, around 45 patients, RAM-PEF study, which did not show any improvement in the 6-minute walk test with eplerenone. So that's one MRA that we can think about. Then we have had ALDO DHF trial, which specifically was focusing on spironolactone. Again, they failed to show any improvement in 6-minute walk test for this HFpEF patient population. Now, has there been a specific study using finerenone to look at the 6-minute walk test in HFpEF population? No, but there was a pre-specified analysis of
Yes.
the randomized trial where they were focusing on KCCQ index, and they saw the improvement in the KCCQ, speaking for the exercise capacity and the improvement of their quality of life, which kind of creates again a very strong I don't want to say indication, but a suggestion that to lean over towards one MRA when you're talking about improving their 6-minute walk distance, which is a very complex thing. Left atrial pressures, diastolic dysfunction, fibrotic tissue level improvement that might be contributing to the improvement in the 6-minute walk distance.
What about this, Dr. Hussein Hashmat, going back to you about the finerenone use in heart failure. Is it guidelines based now or not yet?
In the Canadian guidelines.
Okay, when will be in European or American?
I think the European guidelines, the latest, were published before the release of the fine arts.
So the next one
So
will be in
it's
August.
not in the American.
We'll have an update maybe in August, maybe.
No, let's see.
Yeah. So currently, how do you use finerenone in heart failure? Hashmat?
Not for reduced ejection fraction, of
No,
course,
for
because
HFpEF.
for non-reduced, yeah, almost everyone. Looking at the data, the benefit is stronger than the benefit that we have from SGLT2 inhibitors. So as long as there is no hyperkalemia, I mean, the potassium is 5 or less.
Anything you measure before you do that? I mean, you've done the
Potassium, the
echo, everything.
creatinine.
That's it.
Yeah,
Nothing else.
that's it. Nothing else. No. These are the two issues, the potassium and the creatinine. And then based on the age and the EGFR less than 25, you don't start. And then you start by 10 or 20 based on the EGFR, then you escalate. If the EGFR is maintained, then you can go up to 40.
Yeah. I mean, UACR and how helpful that Agrawal for cardiologist, not for nephrologist.
I think more recent with the PREVENT calculator, which is the most recent calculator from American Heart Association, they have included urine albumin creatinine ratio as part of risk calculation. So I'm very happy with that because we have known for the last 3 decades that urine albumin creatinine ratio, when it's high, it means more cardiovascular events, higher risk profile. So that's already there.
But that get affected by many things as well, no? By infection, by running, by all that. How many times I have to do it too?
Yes. So for example, it depends. I'm measuring it in the inpatient setting or the outpatient setting. So for example, if the patient is coming to me for the clinic, right, and I want to do their baseline cardiovascular risk assessment, I have to measure their urine albumin creatinine ratio and also to have the proper profile of their kidney function as per the most recent KDIGO guidelines. EGFR is incomplete. We need a urine albumin creatinine ratio so that we can stage them based on the glomerular function and the albumin urea. So for both of those things, I think it's very helpful. And as you mentioned, there will be other conditions that they might be kind of changing it. So I at least myself repeat it 2 times before saying that it's abnormal. So you do it once and then you repeat it again next time or after 4 weeks. Or if there is an acute insult, you wait for that to resolve and then repeat it. And when it's high, still high, then you say, okay, this is high. Because you're not going to lose a lot between that 4 to 8 to 10 weeks in repeating that urine albumin creatinine ratio. The whole idea is we have to measure it and then we have to retest it at least once and then act upon it.
Okay, I think the question which remain about AI, which we are learning about AI, how AI will help us to risk stratify patient and start. I mean, any one of you want to answer that? AI in detecting what HFrEF and HFNERF, I don't know, early.
Now the modern echo machines, they can be operated remotely using a robot. And now many of the machines, you just have to acquire the apical 4-chamber and the apical 2-chamber, and they calculate the ejection fraction automatically without us having to trace the borders anymore. So that's one application. And that's the only one I'm aware of.
Yeah. I think some of the studies that I have come across, because when we are saying HFrEF or HEF, NREF or MEFREF or PEF or whatever F we are talking about, I honestly call it heart failure 40% ejection fraction or a non-40. So it's right there, heart failure 40. I think we should come up with our own terminology from European,
Yes.
like from the Emirates Cardiac Society, calling it heart failure 40 and non-40. That's simple. Anyways, but I think the role of AI, this heart failure thing has a key thing. First, you have to say that the patient has heart failure, which can be clinical symptoms, chest X-ray congestion, all of those things are biomarkers. Then only you're jumping to the ejection fraction to phenotype them. That's where the role of AI also comes in, because AI can take a lot of data. For example, if a patient is filling a survey, or can obtain a lot of biomarkers and kind of say that this patient has heart failure, then the echo machine using that AI algorithm can say what type of ejection fraction they have. So I think there is definitely a role. Humans are already doing it. AI just makes it more efficient and more faster. We all do this. Honestly, AI is just making it things faster. Instead of 2 days, it's going to take probably 20 seconds or 30 seconds when you punch in the data. So definitely more and more studies and algorithms are getting approved for it.
Okay, I think we are almost reaching the end. So we are not talking about an organ here, heart failure. We're talking about system that under stress. CKM really bring us together. We need to act early, and we have early detection. We have to how to define the patient population that can benefit from this life-saving medication, finerenone. Both Professor Hussein Hashmet and Dr. Agarwal, both are cardiologists, but tonight they were CKM experts. They put things together. Inshallah, we'll think CKM go forward with the expert cardiologist input. Thank you, and thank you, Bayer, and thank you, Icon. Good night.
Thank you.
Thank you so much.
Good night.